All right, you guys are good.
Sounds good. Well, hi everyone. My name is Vraj Patel. Like Tulsi said, we're presenting today on PAE, prostatic artery embolization. Uh, so thanks to my co-host Alec, as well as our advisor, Dr. Siskin, for helping put this together and making sure that we have something, hopefully of decent quality for you guys here today. So before we get started, I just want to ask everyone if you can, or as many people as that feel comfortable in doing this, to join our poll everywhere that we have here. We want to make this session a little bit interactive, so we're doing that by a mix of, asking you guys to speak up in the middle of the presentation, as well as a couple poll everywhere questions here or there. So I'm just going to stop here for a quick minute just to give everyone a chance. And don't worry, you will get this information a little bit later on in the presentation, right before the first question as well. Okay. And with that, I want to take you guys through a case. And this is how we're going to be going through like the background of BPH and PAE in general for this presentation. So let's say that you're in clinic right now and you have John Doe come in. John Doe is an 82-year-old man, comes into the clinic complaining about how he gets a sudden urge to go to the bathroom every 30 minutes. This obviously disturbs his daily routine and continues into the night, disrupting his sleep. On further questioning, Mr. Doe reveals that he often strains a great deal to try and relieve himself, but despite this, he noticed only a dribble of urine released each time he has to go to the bathroom. At the end, he often feels like he still has to pee, but he usually cannot get more out. So again, if you haven't joined the poll everywhere, it's right at the top of the screen. And right after this, we're getting into our first poll everywhere question, which is based off of the brief vignette that you guys just had the chance to see, what is your differential diagnosis for this patient? Yep. And BPH is definitely one of them. Yep. Uterine stricture, cancer, definitely. UTI could also cause some of these symptoms. Yep. Yep, general term for everything that we're seeing here. Yeah, with that, I think that's a pretty good differential diagnosis to work off of. And so in this case, we have benign prostatic hyperplasia. If those of you that were astute enough to hear Tulsi tell you like what we're presenting about, probably could have guessed that based off of, just like the patient population that this trial was done in. And so what exactly is BPH, benign prostatic hyperplasia? Well, it's a non-cancerous enlargement of the prostate, and it's actually fairly common. Over half of men over the age of 60 will end up suffering from some level of BPH. The actual severity may vary, but you will see enlargement in those men's prostates. And then it is a major cause of lower urinary tract symptoms, or LUTS, as we like to call it. And that's a lot of what we just saw before with like the difficulty voiding and things along those lines. So from LUTS from BPH can also end up causing other problems if you let it get too severe. If the obstruction gets bad enough, you can cause bladder hypertrophy and hydronephrosis, which is the basically backup of urine. And this increases the chance of developing a UTI, as well as can cause renal function to deteriorate. And obviously, this is not something that we want to do. So, usually on top of trying to improve a patient's life, we also want to avoid these complications. And that's why we generally try and treat BPH before it gets too severe. So let's talk about a little bit about the symptoms and identifying factors. Here you see again the short clinical vignette that we had in the beginning. And if you guys could just unmute yourselves and like tell us like something that you used to come up with your differential diagnosis, essentially.
The fact that Mr. Doe is straining when urinating.
Mm-hmm. Oops.
Mr. Doe is demonstrating nocturia, so he's waking up in the middle of the night. He's also having urinary frequency going every 30 minutes. Pretty classic LUTs.
Yep.
And the urgency is a classic important factor as well.
Mm-hmm.
I didn't see incontinence, though. That might be important as well.
Yep, it is. Anything else you guys saw? There was a couple things, and if not, we'll be going over them in just a second. As you guys might have seen, I accidentally leaked the answer a little bit.
The sensation of retained urine.
Mm-hmm. Yep. Okay, I think that's good enough. Like clearly, like Mr. Doe here is exhibiting a lot of the signs and symptoms that we look for BPH. So in this case, like what we should have picked up on is that Mr. John Doe is 82 years old, so over that age of 60. And when you are an older male, like the BPH is definitely a lot more common. So it's something that definitely should be on your differential. The sudden urge, like we mentioned, and also like the fact that he gets it fairly often, every 30 minutes. Nocturia, like someone else mentioned, the straining, like Satya mentioned. We also see dribbles of urine, also like a factor because of the obstruction and the fact that he often still feels like he needs to pee, that sensation of retaining in urine. Those are all like signs and symptoms that should at least alert you that BPH is potentially one of the causes of this. And so these symptoms we call LUTs, lower urinary tract symptoms. And for BPH, we can basically split them up into two different two different types of symptoms, I'm sorry, obstructive symptoms and irritating symptoms. So obstructive symptoms, there is the acronym for WISE, which is weak stream, intermittent stream, straining, and incomplete emptying. And irritating symptoms, so like what just might bother the patient more so, and that's has the acronym of FUN, frequency, urination, and nocturia. So if you are taking STEP or something like that and you need to memorize the symptoms for BPH, WISE FUN is a very quick and dirty way to memorize this. So now let's go into the pathophysiology of BPH. First off, BPH is what we call nodular hyperplasia, meaning that it's not hyperplasia necessarily in one specific area, or one specific lobe or generalized, but like different individual points. You'll see these like nodes, essentially, why we call it nodular, like small little like sections essentially of hyperplasia instead of an overall generalized hyperplasia. It often occurs in the transitional zone. So if you look at the figure that we have here, it's what we see here in purple. And it's essentially the area right around the urethra, essentially, which is why hyperplasia in that region is more likely to cause obstruction, since if we have hyperplasia and increased volume essentially in that region, it's going to narrow the opening. We have the urethra, and that could compress the urethra into a narrow slit, and in some cases maybe even close it completely if we don't do anything. The exact cause of prostate enlargement is overall unknown. We don't really know exactly, the reason why this happens, but however, we do know that androgens have a permissive role, meaning that they're required in order for this to happen. There was actually a study done previously in, many years ago, like I believe this was in like the, decades ago at least, and done in castrated males. And actually you see in that patient population that BPH is basically non-existent. So we know that those androgens that are produced in the testes are pretty important in the development of BPH. So from here, we have to look at what is next for John Doe. We had, essentially just done a brief history with him and asked him what the problem was. But from here on, we need to do a more thorough physical exam. And usually that includes a digital rectal exam. The reason why we do this is because through a DRE, we can palpate the prostate and actually feel if it's being enlarged or not. And if you've done serially, you can actually potentially see the progression of like the prostate getting bigger. Another thing that we can do is do a urine analysis, looking for, different microorganisms in there, see if there's glucose in there. Basically, just look at the characteristics of the urine and see if we can rule out other causes of LUTS. If you see like some sort of microorganism, you can potentially be a little bit more suspicious of like a UTI causing these problems. But if you don't, you can almost like rule it out essentially, and BPH rises a little bit higher on the differential. Same thing with a blood test. You're doing that to measure things like the creatinine and like other measures of kidney function, and see if like we're having a problem in the upper tracts essentially. See if we're having any backup problems, and then through that, like we can also do some other lab work as well, like a PSA level. As like the prostate tissue enlarges, you should see an increased serum PSA level. So that could potentially signal you towards that, though it's not diagnostic, since we know that prostate cancer can also cause that. You could do a urine flow study, which essentially is using a machine like you see one pictured, and essentially do like a measurement of like how the flow looks like of urine over time as someone is voiding, and doing a post-void void diary for like over a course of a week is something else that could be useful, as well as the use of established questionnaires like the IPSS. We'll talk a little bit more about that later on when Alec starts talking about the study a little bit. But all of these are, more of like the clinical and testing things that could be done to use to diagnose BPH. However, if you are still unsure, you can do some level of imaging, maybe a biopsy as well. And while they may be helpful, if you don't need it, you don't have to be done. Diagnosis is usually done with the presence of LUTS and no evidence of the non-BPH causes of LUTS. And that's why a lot of these things we see, urinalysis, we're doing it to rule out other causes. Blood tests, we're using it to rule out other causes. So it's more of a diagnosis by elimination more than anything else. So from here, how do we treat John Doe? Well, first off, we can, if it's early on and like not too bad, we can initially start off with just some lifestyle modifications, just some small things like avoiding fluids around bedtime, so he potentially doesn't have to go to the bathroom as often during night, basically trying to address his symptom of nocturia. We can ask him to reduce consumption of weak diuretics like caffeine and alcohol, and also do something called double voiding. Basically, go to the bathroom, he voids, waits a minute or two, and then tries to void again, and that could potentially help him if his BPH isn't super severe at that point. If we need to be a little bit more aggressive, we can do some level of medical treatment. So in this case, we have often seen some level of alpha-1 blockers to start off with. If those don't work, we can use phosphodiesterase type 5 inhibitors, and as well as antimuscarinics, and like try and see if those work. And all of those essentially is used for symptom relief to try and allow him to continue living life without seeing those negative effects of BPH. Another thing that we can try is to prevent progression, and we can do that with 5-alpha reductase inhibitors like finasteride. And the reason why this works is because, like we mentioned, androgens are very important in the development of BPH, and if we can inhibit like the formation of some of these strong androgens, we can actually potentially prevent the progression of BPH in these patients. So if at that point, like even with medical treatment, we're still not seeing the results we want, we can get even more invasive. And one of these ways to do that is through surgical treatment. In this, there are a couple different ways, and basically there's 2 different categories. Basically a non-ablative treatment, mostly which involves the essentially placement of a tool to either keep the prostate from compressing the urethra to maintain its patency, or to place something inside of the urethra to essentially open up the urethra to also maintain patency. Maintaining patency is the overall goal for almost all surgical procedures. The other subset are ablative procedures, and basically we can essentially call them TURP and its variations. TURP is transurethral resection of the prostate. Essentially, you're putting in your device, and the exact device depends on like what exact procedure you're doing. But at the end of the day, you're using that device to essentially ablate, or essentially kill off and eventually remove the tissue around the prostate, around the urethra, to prevent the prostate from compressing the urethra to the point where a person can't really void effectively. And there's a whole bunch of different variations of TURP, and all of it basically is just using different means to ablate that tissue. You can use electricity, you can use lasers, you can use water vapor. All of them, at the end of the day, though, have the same overall mechanism of action, where you're ablating the tissue around the urethra. And finally, we need to talk about, obviously, where VIR fits in, and that is prostatic artery embolization. So here we have some quick anatomy for you to review in terms of vasculature. The prostatic artery is overall a branch of the vesicular prostate artery, which comes off of one of the branches of the internal iliac, specifically the anterior division. And the whole point of this procedure is to limit blood flow in that area that's going to the prostate, and hopefully that will end up causing ischemic necrosis of the prostate and end up leading to a reduction of the prostate volume. So if you're actually doing a procedure, doing a PAE procedure, usually traditionally what ends up happening is that you get access through either the radial artery or the femoral artery using the Seldinger technique. You navigate to the internal iliac, selecting for that anterior division that we were talking about. From there, you can select the prostatic vesicular artery, which is essentially just that like little nub, essentially, that pretty quickly splits off into the prostatic artery and the vesicular artery. From there, you want to get into as close to the deep branches of the prostatic artery as possible. So you're going to be using pretty small wires, like along the lines of like 2.5 French or catheters and wires, not just wires, obviously, to get to those deep branches. And then you're going to start introducing your embolic agent. It could be microspheres, it could be polyvinyl alcohol, but just something to limit blood flow until stasis is achieved in that area. And once blood flow is limited, like I mentioned, hopefully you're going to see ischemic necrosis of the prostate and lead to that reduction in volume. So after the procedure, what do you normally have to do? Well, you have to, do some level of follow-up with the patient. Usually, these procedures can be done in an outpatient setting. However, some centers do prefer overnight observation. You normally do want to give antibiotics 1 week post-procedure, and as well as NSAIDs for the pain control, and a couple of different other meds to help with bladder spasms and pelvic discomfort, all of which are some side effects of the PA procedure. You have an increased risk of UTIs post-procedure. You have some level of pelvic discomfort because you may potentially embolize other arteries and other vessels that may go to other areas. As you can see in this picture, we see a couple different vessels in the area that go to a couple different other structures. So if you get some non-target embolization in those areas, you could see some effects in those areas. But overall, these symptoms are fairly minor, and as a collective, we call it post-PAE syndrome. And generally, post-PAE syndrome resolves on its own within 2 to 3 days post-procedure if it does come up. You do want to do some longer-term follow-up just to make sure that we see improvements both qualitatively and quantitatively. And quality of life, as well as the established questions. And generally, these are scheduled both 1 and 6 months out. However, if you're doing a study, like, you may do it more or less frequently, just depending on how your study ends up working out. So that in a nutshell is what PAE is. And now I'm going to hand it over to Alec to actually talk about the study that we're here to talk about today.
All right. Thanks, Vraj, for that great background about BPH and prostatic artery embolization. So now we'll start the discussion about the article, which is entitled Prostatic Artery Embolization versus Medical Treatment in Patients with BPH. This was a randomized, multi-center, open-label phase 3 superiority trial recently done in France. Next slide. So the purpose of this study was to compare changes in lower urinary tract symptoms in patients with BPH after PAE versus after combined medical therapy with dutasteride and tamsulosin. Next slide. The participants in this study were patients aged 50 to 85 years old with bothersome lower urinary tract symptoms, despite treatment with alpha blockers for more than a month. The inclusion criteria were patients who scored above an 11 on the International Prostatic Symptom Score, or IPSS, who scored above 3 on quality of life, and those who had a prostate volume of above 50 milliliters on MRI or ultrasound imaging. I'll get into more about the IPSS and quality of life on the next slide. The exclusion criteria were patients who had a severe allergy to iodine, those with renal failure, and those who were treated with 5-alpha reductase inhibitors in the last 6 months. Next slide. So IPSS, as Vraj sort of started saying, it's a questionnaire that determines the severity of BPH symptoms. Essentially, it consists of 7 questions assessing urinary symptoms and 1 question at the end assessing quality of life. And patients respond from 0 to 5, 0 being not experiencing the symptoms at all, 5 being always experiencing the symptoms. So some of these urinary questions include incomplete emptying, urinary frequency, intermittency, urgency, weak stream, draining, and disruptance in sleep. And on this questionnaire, a higher score corresponds to more severe symptoms, lower score corresponds to milder symptoms. Next slide. So the methodology for this study. Patients were randomly assigned to either PAE or combined medical therapy. And obviously, because it was not possible, treatment was not masked from investigators or participants. Obviously, patients will know if they had surgery done on them. So this schematic sort of shows how the investigators went about this. Initially, there were 105 patients assessed for eligibility. 15 were excluded, and then 90 underwent randomization. So 45 were assigned to receive PAE, and 45 were assigned to receive the combined medical therapy. Next slide. So the combined therapy group received oral dutasteride 0.5 milligrams and tamsulosin 0.4 milligrams per day for at least 9 months. And in the PAE group, they received tamsulosin 0.4 milligrams per day from randomization to 15 days after their procedure. And then, of course, the PA was performed according to standardized technique. They used 300 to 500 micrometer embospheres from Merit Medical. And sort of as Vraj was describing, they got access through the femoral artery, then catheterized the 2 prostatic arteries, and then they did proximal embolization until they achieved complete stasis, and then distal embolization. Next slide. So this is just a table talking about the baseline characteristics. The take-home message here is that randomization was successful because the clinical characteristics on the left were pretty balanced between the 2 groups, the PAE groups and the combined therapy. This included things like prostate volume, flow max, post-voiding residual, IPSS, quality of life score, IIEF, which I'll talk about in a second, all pretty similar between the two groups. Next slide. All right, so outcomes. The primary outcome in this study was a change in IPSS, and then there were a few secondary outcomes that were looked at. Number one was change in quality of life score. Another one was the change in the International Index of Erectile Function score, or IIEF. So this is basically another questionnaire that assesses sexual function. Patients are asked questions about erectile function, satisfaction with intercourse, orgasmic function, and sexual satisfaction. But the confusing thing is for this one, low scores correspond to severe dysfunction, and high scores correspond to no dysfunction. That's opposite from how IPSS is scored. And then some other secondary outcomes were changes in prostate volume, PSA, Flomax, and post-void residual. All these outcomes were assessed 9 months after randomization was done. Next slide. All right, so I sort of took you through randomization, but a few more things happened after that. So in the PAE group, one patient was excluded because they didn't have IPSS data at 9 months. And in the combined medical therapy group, 2 patients were excluded because they didn't have that data. So 44 patients in the PAE group and 43 in the combined therapy group made up the intention to treat analysis. But then there were some more patients who didn't adhere strictly to the protocol. 4 in the PAE group had either had another BPH treatment before the 9-month visit, and then 13 in the medical therapy group either had another BPH treatment or they weren't adherent to the regimen. So for the per protocol analysis, that left us with 40 patients in the PAE group and 30 in the medical treatment group. Next slide. All right, so here's a question for the audience. What are the benefits of intention to treat analysis versus per protocol?
And if you guys need to join the poll everywhere again, the QR code is right at the top right.
All right, looks like we got quite a few answers in. Oh, yeah, so surprise, if you had scrolled down, the answer was all of the above. Next slide. Okay, so first of all, the difference between intention to treat and per protocol analyses. So intention to treat considers all randomized participants, even those who didn't strictly adhere to the protocol, versus per protocol, which considers only those who strictly adhered to it. And some pros of intention to treat are that it preserves randomization. It has greater generalizability, because it reflects the clinical setting by considering non-compliance. It is a conservative form of data analysis. It tends to underestimate the treatment effects, and it maintains the sample size. This is contrasted with per protocol, which does not preserve randomization. It's less generalizable because it's difficult to say whether the differences are due to treatments or other reasons, like why patients adhere to the treatment or why they didn't. And it tends to overestimate the treatment effects, and it reduces the sample size. So According to the Consolidated Standards of Reporting Trials, or CONSORT, they consider ITT the gold standard approach. So next slide. So these are the results. I'll take you through it slowly. But basically, the investigators did both an intention to treat and a per protocol analysis. What you see here is the intention to treat analysis. So next slide. So remember IPSS, if they have a higher score, that means they have worse symptoms. And so in the PAE group, there was a mean difference in their score after 9 months, a mean decrease of 10, versus in the medical therapy group, there was a mean decrease of 5.7. And that was a statistically significant difference favoring the PAE group. And also, if you look at quality of life, in the PAE group, there was a change of -2.8 after 9 months, and in the medical therapy group, there was a change of -1.1 after 9 months. Also, a significant difference. And in addition to the intention to treat analysis, they did a per protocol analysis, which showed similar results. So next slide. And then also importantly, when they looked at IIEF, so remember for IIEF, a lower score means worse symptoms and a higher score means better. So when they looked at this in the PAE group, after 9 months, there was an average increase of 8.2. And in the medical treatment group, there was actually a decrease of -2.8 after 9 months. So that was a significant difference between the two treatments. And then finally, they also examined some of these secondary outcomes like prostate volume, PSA, Lomax, and post-void residual volume. And so for prostate volume in both the PAE group and the combined therapy group, they saw pretty similar decreases after 9 months. They weren't really different between the two groups. PSA, similar decreases in PAE versus medical therapy. Lomax, similar increases in both. And then post-void residual, similar decreases in both groups. And actually, so for this analysis, they also stratified by severity of the IPSS score, moderate versus severe, and they got similar results as what's shown in this table. Next slide. So this is just a graphical representation of what I was talking about before. So in our top panel, we have the change in IPSS. So PAE, as you can see from randomization to 9 months, pretty significant decrease in IPSS for a lot of patients. Some not as much, but a lot of people had pretty significant results. Versus combined therapy, modest results, but not quite as strong as in PAE. And some patients actually had an increase in their prostatic severity score. So, and then in the lower panel, they show changes in IIEF score. Again, an increase in IIF is good. And in PAE, you did get more patients showing an increase in IIEF from randomization to 9 months than you did in the combined medical therapy, where the results were a bit more scattered. Next slide. So they actually followed the patients up also after 24 months. And so 80 of the 90 total patients completed this 24-month follow-up. That was 42 in the PAE group and 38 in the combined medical therapy. And so in the PAE group, after the 9-month outcomes were assessed, 5 patients underwent prostatic surgery, mainly holmium laser prostate surgery, which is like a minimally invasive procedure to kind of like ablate the prostate. And then in the combined therapy group, after 9-month outcomes were assessed, 14 patients actually underwent PAE, and 4 patients also underwent prostate surgery. And importantly, in the PAE group, both reduction of IPSS and sexual function as assessed by IAEF remains stable at 24 months. Next slide. Also as part of their analysis, they did a cost analysis. And so for the PAE group, the total cost was $5,252, which included the initial admission, the procedure, and the follow-up, versus $1,311 in the combined medical therapy group. This study was done in France, so although it may not be generalizable to the US, it's clear that PAE is significantly more expensive than medical therapy, which is, I guess, expected. And then another important thing to note is that no treatment-related serious adverse events requiring surgical treatment or rehospitalization in both groups. So it confirms what we know about PE, which is that it has a pretty favorable safety profile. Next slide. So just to kind of like rehash the take-home points here. So for this study, the study found that urinary function as assessed by both IPSS and quality of life was significantly more improved at 9 months after PAE than after combined therapy in both modified intention to treat and per protocol analyses. Number 2, sexual impairment as assessed by IIEF was significantly more improved at 9 months after PAE than after combined therapy. And also of note, in the PAE group, both reduction of IPSS and sexual function as assessed by IIEF remained stable at 24 months. And also of note is that there was little difference in functional outcomes, such as prostate volume, PSA, flow max, and post-void residual between the two groups. And then as their cost analysis showed that although the cost analysis may not be general to the US, it's clear that PAE is significantly more expensive than medical therapy. And then lastly, no treatment-related serious adverse events occurred requiring surgical treatment or rehospitalization, which confirms that favorable safety profile of PAE. All right, next slide. So another question for the audience, just a pretty simple one. Do you think the study was successful in its purpose? And yes, obviously the answer is yes, it was successful in achieving its purpose. It pretty, in my opinion, convincingly showed that there was a significant improvement in lower urinary tract symptoms with PAE versus medical treatment. So next slide. But however, this study did have a few limitations. First most was that it was an open label trial. It's impossible to blind the patients and the investigators to the treatment. You know whether you got surgery or not. And the outcome measures were subjective questionnaires such as IPSS and IIEF, which could have been biased based on whether they received surgery or not. So that's definitely an important consideration. Number 2 is it didn't compare PAE to other medical treatments. Vraj took us through, there is a lot of other medical treatments besides what was examined, such as muscarinic receptor agonists or phosphodiesterase inhibitors. Number 3, embolization was performed in centers with varying levels of experience. I don't think that this was too much of a factor, but still worth considering, as there was no adverse effects requiring rehospitalization, period. Therefore, no difference between different centers. Number four, the duration of treatment was only 9 months, and 9 months may have been too short to observe effects. Patients could have had recurrence of symptoms and maybe required another procedure intervention later on. Although they did follow 80 of those 90 patients to 24 months, and they showed that their changes in IPSS and IAF were maintained. And then I sort of already talked about this, but number five, the questionnaires could definitely have been affected by detection bias. So yeah, next slide. So thanks for giving me the opportunity to present, and I'll turn it over to Dr. Siskin. What did you have for the major takeaways from this study?
Well, thanks, guys. First of all, I appreciate being here tonight, and you guys did a great job on the presentation and on the review of the article. It's a really nice job, and it's a challenging subject. So I think it's hard not to walk away from this study and say, wow, PAE is a really nice option for patients with LUTS secondary to BPH. And I think that this study does go a long way towards showing that PAE has a role probably as really second-line therapy after medical therapy. And I think you can even make an argument that it should be in place of medical therapy, but I'm not 100% sure that's a winnable argument. So I think that understanding that there's efficacy to this out to 24 months. I think that there are a couple of maybe more nuanced points embedded in this study that are important to make, and some of it was, we kind of started looking at this in the chat. So the first thing is the technique that was used and the agent in particular that was used. So I think a lot of people who do PAE are kind of settling into using the size embolic that was presented in this study. So that these microspheres, which are flow directed, meaning that they're injected within the prostatic artery, but flow carries them further into the prostatic tissue. And for a very long time at the kind of the early stages of this procedure, there were debates, and there in some ways continue to be debates about the correct size of the microsphere to be used. I like Mark Sapovel's approach to this. I think that 300 to 500 microns, in my opinion, is really the sweet spot for the embolic agent. But as we discussed in the chat a little bit, people are using smaller microspheres in some centers, thinking that they're going to go out further into the prostatic tissue and maybe cause a more definitive embolic effect. Other people are using liquid embolic agents, which will obviously go a little bit further out into the system. Some people are using proximal coils or gel foam behind some of these flow-directed embolics. So I think what that needs to tell you is that the procedure is not necessarily completely mature just yet, that there's still a lot of people with different opinions as to the way it should be done. And you just have to be cognizant of that as you're reading through the literature, because you want to really look at what technique was used, what were the procedural endpoints, and what embolic agents were used, because you're going to see differences in the way people approach their utilization of the materials that are available to us. I think this was especially true early on. Like I said, I think it is evolving to center around this 400 micron size as a good balance between distal penetration into the prostate gland and safety in terms of not going too far to cause potential complications. And I think as you look at a procedure that has some variability in how it's performed, you just have to say, are we really as far along as we can be with our knowledge of this procedure? So it's just something that you should keep in mind as you read about new procedures, and everyone gets enthusiastic about looking at genicular artery embolization or hemorrhoid embolization or even gastric embolization for obesity. I think that there's a whole bunch of exciting things that are out there that people are talking about. But as you look at journal articles and see the variability in technique, just know that we still have a little bit of a way to go before we standardize it. And you look back on procedures maybe like fibroid embolization, I would say for the most part, people perform that the same way, and that speaks to the maturity of the procedure. So just know that. The second thing is the follow-up. I think that 24-month follow-up is great. It's probably as good, if not better, than a lot of the papers that are out there for PAE. But I think that we probably need to do better. And there's been papers published on PAE now for quite a number of years. And man, oh man, it would be so nice, if some of the early authors of these papers just checked in with their patients again, right? And got some 5-year data, 7-year data, 10-year data even. I think that would go a long way towards really creating more believers in PAE as an option for this patient population. But, I think 2 years is really good. And I think we just need to do better as a specialty. So to me, it's kind of hard to ignore the fact that this is a really positive paper, and one that I think anybody who is advocating on behalf of their patients with payers and insurance companies and et cetera, this is one of the first papers we should be showing people. It's a really nicely done paper that really, in my mind at least, demonstrates the utility of PAE, but we need more papers like this, is what I would say.
Nicholas, do you want to ask your question?
Sure. Hey guys, Alec, Vraj, amazing presentation. Really considerate with different approaches to management of BPH. Just one question for both the presenters. Given that the sample size, if I got that correctly, originally was 105, and I'm having 80 patients final in their final study. What are your thoughts on having this small sample size, relatively trying to introduce new treatments to, let's say, a larger patient population when we think of like American centers out here? Do you think that further studies would show similar results, given like the IPSS has some subjective nature to it, or do you think that the same results would hold true here?
I think that's a really good question to bring up, and afterward, I'd love to hear Dr. Siskin's take on this question as well. My personal opinion, I feel like, like Dr. Siskin had mentioned, like PAE is still progressing and maturing as a procedure. This is like a natural progression that we have to have. Like the initial studies, like aren't going to have the, like thousands, tens of thousands patients available, like if it is something that's done on like a scale of the US population. That said, do I think that to a certain level, like we would be able to see similar results? Yes, I think that the actual, statistics done in this study like showed pretty significant values, and I'd expect to see like some level of benefit through PAE. That being, we did talk about that there are limitations to this, and like that could sort of preclude getting the exact same level of results that we see in this paper as in the United States as a whole. But I think it's at least like something to be optimistic about.
I would add that I'm sorry, go on, Alec. I don't mean to interrupt you.
No problem. I was going to say also in the paper, they did a power analysis where they said like to detect a 4-point difference in IPSS between the two groups with 80% power, that they needed 37 patients per group. So they did consider the sample size in this, but of course a bigger sample size would always be better to try to show a significant difference with between the two groups.
Yeah, I mean, it's hard to disagree with that. I think to answer your question, to me, you can look at some of the meta-analyses that have been done through the years. This is not the only study that's been done. There have been many other studies. And if you combine kind of similarly performed studies into a well-done meta-analyses, what we have found, and people who've looked at this have found, is that the IPSS score does consistently improve after PAE. So you may not have a 1,000 person study that's done to be able to show that, but a well-done meta-analysis can really answer the question the same way. So I think that most people who perform this procedure do feel that this can be applied to larger populations, and that you don't necessarily need 1,000, 2,000 participant studies to prove that or demonstrate that. I do feel, I will add to it, that I think in terms of sexual function, I don't know if these benefits necessarily that were demonstrated in this study would hold up across a larger population. A lot of the meta-analyses haven't been consistent in showing the benefits in sexual function as this study did. So just keep that in mind as well as you look through other literature.
Michael?
Yeah, great presentation, Alec and Vraj. Sorry, I joined a little bit late, so I'm not sure if you guys covered this earlier, but I have two questions for you guys. First, how does PAE compare to other minimally invasive like surgeries for BPH, like urolift or aquablation? And then secondly, what prostate size can you do PAEs in?
I think that's a good question. I know that there have been a couple studies done comparing PAE to like the other procedures. I don't remember the results off the top of my head. I can pull them up afterward and like send them to you individually, and like we can discuss this. Don't know if you know anything more specific, Alec, about that. In terms of prostate volume, I don't. I naturally also don't remember if the article ended up being more granular about it. I just know that, you know, in general, like you want to see prostate volumes that are like higher than 50 milliliters in for PA, at least for the purposes of this study. And yeah.
Yeah, I think that's true. I mean, we have found we've a lot of studies that are out there looking at PAE to treat large volume prostates have been really successful in their results in terms of, you know, either getting rid of chronic indwelling Foley catheters or just reducing, you know, various symptoms like were reported in this study. I mean, our anecdotal take on this is that the patients with very large prostate glands do really well after PAE. Now, while the holmium laser treatment that was kind of discussed in the chat is very good for that and is an option for patients with larger sized prostates, the urologists don't have as much kind of in what they have to work with to treat those patients. And to me, PAE has a real niche there. I think there are a lot of people walking around with very large prostates, and you know, I think we've seen some of our best successes in some of the patients that are greater than 80 ml in terms of the volume of their prostates. There really isn't as much data comparing PAE directly to some of these newer urologic treatments like UroLift, like you mentioned. So I think that, you know, we're still kind of waiting on that. I think that's going to be the next round of data. But obviously, those numbers are a little bit harder to come by right now. In terms of comparisons with TURP, you know, I think there are benefits to both procedures. In some of the early randomized trials, TURP was shown to be a little bit better in terms of outcomes and in some of the outcomes for these patients, but it wasn't like it was wildly discrepant. And so if you look at that and you say, well, patients with PAE still receive significant benefit after this procedure, it's far less invasive than a TURP. And so there are a lot of people that still look at that data and feel, okay, fine, you know, TURP scored a little bit higher in this or a little bit higher in that. But the reality is that patients still did very well after a PAE, and that it still belongs in the conversation with a lot of these other treatment options.
Hi, Dr. Siskin. Great presentation, Vraj and Alec. I was just wondering if you see a use for PAE kind of beyond BPH, like could it be used for cancer or prostatitis, considering that blood flow contributes to all of these issues?
So I'm not sure necessarily about its role in prostatitis, but I think for cancer patients, especially those who might have some bleeding symptoms, I think that PAE is you know, also belongs in that conversation as well. I don't think we can look at it personally as a standalone treatment for cancer. I'm sure that there are people who are sitting there wondering if things like Y90 and other tools that we have may be valuable once we figure that stuff out. And I've heard people talking about that before. But I think for now, it might be helpful in just maybe just softening some of the symptoms that patients with advanced prostate cancer might have.
Awesome, thank you. There's a question in the chat that I'm going to read out. Given the ongoing cost of medical therapy, I wonder if anyone has done the math as to when PAE, assuming durable treatment, becomes lower cost than medical therapy, maybe around 5 years. I was also curious if anyone could comment on the generalizability of this demographic, only French patients, to the US. Probably pretty similar, but something to consider.
I don't necessarily see why the generalizability wouldn't be relevant in terms of comparing French men with American men. Maybe there are other differences, but I'm not so sure that in terms of how they would respond to prostatic artery treatments would be different. I'm really not sure. I just don't think I can speak offhand about the cost comparisons. I'm not sure about that. But just keep in mind that there's not a whole lot of really solid 5-year data, especially in the American healthcare system, to understand about costs. So yes, the Lisbon group has been studying this for quite a long time, as has the group in South America. And so, I think that there's data to be had in terms of cost, but in terms of 5-year data and understanding where it kind of starts to look very favorable compared to medical therapy, which is obviously far more commonly utilized, I'm not sure I would know the answer to that question.
Hey,
Marvy?
Go ahead.
Hey guys, first of all, great presentation, Vraj and Alec. Dr. Siskin, I was wondering, I know we had talked a little bit about earlier about the different types of embolics that they use for PAEs. What do you like to use in your practice? And can you comment about like the like using glue for PAE, and like what are your thoughts on that?
So we have been using Embozine, which is just another microsphere. We use 400 micron Embozine, and so it's really very similar to 300 to 500 Embosphere. It's just a little bit of a tighter size range. So when you look at these ranges of embolic material, there's always particles that are a little bit smaller than the lowest number and a little bit larger than the largest number. And so we just, for whatever reason, got used to using one with a tighter size range, but they're relatively similar, although the compressibility is a little bit different between the two types of microspheres. I don't think enough to appreciably cause differences in outcomes given the similar size range. I think in terms of using liquids, I think we just have to be a little bit careful, right? So when you're doing these procedures, you have to have an incredible knowledge of anatomy. And I think that in the old days, when we would basically just be in these arteries because patients got into car accidents and were bleeding from them, it wasn't as important to know the names of every artery and where every artery was going, because our goal there was to stop the bleeding and save someone's life. Didn't necessarily matter, with a couple of different exceptions. Now we have to be acutely aware of every artery that's coming off the prostatic artery. We're not interested in causing any bladder complications or penile complications or rectal complications. These are things that could be catastrophic to these men as they undergo procedures. And I think if we're going to be using different agents, we have to have a really good sense of anatomy, where this agent is going, and being able to control where it's going. Glue is a fascinating embolic agent to use. We can speak for an hour just on using glue. Ultimately, it's an art form, and we have to dilute it appropriately to get it to go far enough into the system, as far as we want it to go into the prostatic arteries. And so understanding how it's going to behave is really important. And frankly, I think given the relatively small size of the prostatic arteries that we're often dealing with in PAE, I'm concerned personally that glue would probably occlude vessels faster than we might like. And so it might not go as far out as we like. And if it does, it might subsequently make its way into some of those other arteries that could then cause complications. So that's the reason for using slightly larger microspheres compared to the smaller microspheres. It gives us a little bit more control. And then there's always the question of, do you need to, in some ways, cap off what we're doing? So we go into the prostatic artery, we administer our microspheres. Then the question is, do you put maybe some gel foam behind it or a coil behind it? The group at Mount Sinai talks about that a lot in terms of using even some glue, but they're almost routinely using coils on their way out. I haven't yet really appreciated why that would be the case, since this is a distal embolization that we're trying to do. And frankly, I'm not sure how much it adds, but I know certainly they're committed to it. So it just speaks to my earlier point that we still have a little bit to learn about the ideal technique for PAE. But I'm not a huge fan of using liquids for this, is my short answer to your question, Marvy.
Gotcha. Thank you so much for your thoughts.
Satya?
Yeah, great presentation, Vraj and Alec. Dr. Siskin, I was wondering if you could comment on kind of the efficacy you've seen in your practice between PAE and maybe some of the other medical treatment options, like the finasteride 5-alpha reductase inhibitors. Are you seeing that those are working better than the other medications that were highlighted in the study, or are those patients also somewhat indicated for PAE as an alternative?
So this is a very academic discussion, in my opinion, because for the most part, I think now everyone's practice is different, all right? But we're not necessarily getting patients that are coming in off the street just having found out that they have prostate problems, and that we're kind of orchestrating their entire management surrounding their BPH, right? Most of the time, the patients that we're seeing either have failed medical therapy or have adverse kind of side effects related to medical therapy, or just aren't interested in medical therapy. And so for that reason, I actually am not sure I can answer your question, right? Because the variety, the typical patient that's coming to see my practice, to see me in my practice, isn't really interested in the medical therapy that they've been offered or have been receiving. And so it's hard for me personally to give you a comparison of individualized in my practice for medical therapy versus PAE. What I can tell you is that, and again, we haven't published our data, and I don't think we have plans to, but ultimately, generally, most patients are doing really well after this procedure. And we tend to follow our patients for about 6 months. We work very closely with our partners in urology. And so, you know, we kind of share the follow-up responsibilities for these patients, and we're included in everything that they undergo. We're seeing very few people over the years who've needed redo treatments. We certainly have seen only a handful of patients where we've repeated an embolization. And more often than not, it's patients that maybe we couldn't get one side earlier on in our experience, and we're just better at doing this than we were a couple of years ago. And so it's pretty unusual for patients to come back needing a repeat PAE, and only a handful of patients have needed more advanced surgical fixes, for lack of a better word. We just know that it has a role, and I really think the sweet spot for PAE, in my opinion, is after medical therapy, but before more invasive urologic therapy.
Thank
That's
you.
an opinion. A lot of people are going to think differently.
Another question in the chat. Do you stop medications after PAE for LUTS? If so, when?
I personally like to keep them on it through the first month, and after our first month follow-up visit, I tell them that they can begin to taper off those medications. So I don't believe in changing it right away. I like people to heal. I find that there's an inflammatory response, and I just think getting them through those initial couple of weeks is really important. So I don't stop medications right away.
Okay, awesome. I'm going to ask one more question. I want to respect your time. How many PAE should a trainee get during training to feel competent?
So my opinion is that it's never going to be enough, right? So I think that when you guys look at your when you guys look at different programs that you're going to and look at what you want out of a program, I think you want to make sure that the global experience with embolization is what you're looking for. And I think that you need enough PAEs to understand the anatomy, understand the pitfalls of catheterizing prostatic arteries. But really, I think if you walk away from your training program, it's hard for me to come up with a number. So I'm sitting here thinking, you do 20 to 25 PAEs, you're fine, in my opinion. But that in a vacuum probably isn't enough. If you add 50 UFEs to that, and a whole bunch of liver tumor therapy cases, and a whole bunch of trauma embolizations where you're navigating small vessels and learning those embolic techniques, and a whole lot of GI bleeders, these are transferable skill sets. So, for example, you may not do a lot of PAEs in your training, but if you do all those other things, you're more than capable of doing PAEs, and your learning curve will be really very, very low in getting into doing those procedures. So I think you would want to see at least 20 or so to be comfortable, and seeing those patients in the office as well to understand the nuances of what you've done, what constitutes a normal recovery, how do you recognize adverse events, how do you do patient selection? These are all questions you're going to need to answer. But in terms of the procedural skill set, I think it's all transferable, in my opinion. You just need good broad embolization experience.
That's super helpful. Thank you for your insights. I think this is really great to keep in mind as a lot of us are going through applications soon and thinking about all of this. So thank you. I'm gonna have us close with that. Thank you again so much, Alec and Vraj and Dr. Siskin, for your time. This was a super educational presentation. I hope everyone learned a lot. If any of you are new to our meetings, feel free to follow us at TNVIRJC and putting it in the chat on Twitter and Instagram to keep up to date with all of our meetings. Thank you everyone for being here. Hope you have a great weekend.
Thanks, guys.
Thank you, everyone. Thank you, Dr. Siskin.
Thank you.